to all. We will be talking about the pearls on malignant conjunctival tumors for the next 15 minutes. I extend my gratitude to my mentors, Dr. Shields and Dr. Hunavar, for all the lessons that I have learned so far. Now, basically, our objective for today would be how to clinically diagnose a malignant tumor. How do we differentiate it from the benign tumors that you have already listened to, the diagnostic aids, and some miscellaneous tumors. So we will be mainly focusing on common malignant tumors of the conjunctiva. So I'm going to classify it into non-melanocytic and melanocytic to make it simple. So this is a patient, a 64-year-old Chinese man, who presented with this whitish lesion in the caruncle of the right eye. Can we have the diagnosis from the audience? Or does it look benign or malignant to you? Benign? Why do you think it's benign? So you can see this keratin fill lesion in the caruncle of the right eye conjunctiva. Whenever we talk about keratin, the first thing that strikes us is ocular surface squamous neoplasia. To have a closer look, here you have this keratin fill lesion in the caruncle and surrounding inflammatory or reddish elevation, nodular elevation all around. In fact, histopathologically, after excision, it came as conjunctival granuloma. So we missed out something in the history. He had undergone a lacrimal intubation, which was not removed for the past 20 years, which led to this granuloma. This is a case diagnosed as unilateral blepharoconjunctivitis. Does the audience agree to that? No? Corneal OSSN, exactly. So what the physician really missed was the presence of the keratin. You can see specks of keratin in this diffuse involvement of the cornea and the conjunctiva. This was in fact corneal SCC. Yet another case. This patient was diagnosed to have a corneal scar. He underwent phototherapeutic keratectomy once, and then he again had a recurrence of this so-called scar after 2 years. Do you agree it's a scar? Well, as you can see here, again he has got these specks of keratin. And if you closely observe, there is an extension of conjunctival thickening along the limbal margin of this area. And if you see the cross section, you can see that it's involving the epithelium of the cornea. In fact, it was a corneal OSSN. Yet another case. This was diagnosed as necrotizing scleritis. Of course, it can fit into it. The entire sclera is necrosed, but you can see this lump of keratin which is overlying the scleral necrosis. It was in fact a conjunctival SCC which has intruded the sclera, melted the sclera, and with an intraocular extension. So these are the things that you have to look for in your clinics to differentiate certain entities from a benign and a malignant one. Yet another case. So this patient doesn't give any history of a conjunctival lesion at birth or otherwise. He suddenly appears in the clinic telling, since 2 years he have been, noticing an elevated lesion over the conjunctiva. This is a clear-cut case of a malignant conjunctival melanoma, a pigmented lesion. But in fact, if you see very closely, he does have a neval component over here. So it's something like a nevus turning into a conjunctival melanoma. So if it would have been diagnosed earlier by the treating ophthalmologist, this could have been prevented. In fact, the more thicker the conjunctival melanoma is, the more the chances of systemic metastasis and mortality. So going on to the first one, ocular surface squamous neoplasia. As you all know, it's a blanket term of a precancerous and a cancerous lesion. And it has got a clinical spectrum of dysplasia, carcinoma in situ, and squamous cell carcinoma. We will be dealing with squamous cell carcinoma of the conjunctiva at this point. It's considered to be the most common conjunctival malignancy. In fact, it is a low-grade malignancy compared to conjunctival melanoma, but it can be aggressive in immunosuppressed patients as well as in those who have systemic association. Now, what are the systemic association of squamous cell carcinoma? Xeroderma pigmentosum, immunosuppression, HIV, post-organ transplant, and palmoplantar keratoderma. It's a very, very rare syndrome. Now, as you can see here, this child had developed squamous cell carcinoma very, way younger in her age, and she had recurrence and bilateral presentation of squamous cell carcinoma. This is a patient, a very young patient. He was 32-year-old, but you can see the exuberant lesion that he has developed because he was immunosuppressed. Same in this guy, he was HIV, and in fact this guy was diagnosed to have HIV after he presented with a conjunctival lesion, because we had a very young patient presenting with squamous cell carcinoma. The first thing that we do is send the patient for HIV serology. Well, another case where the patient has had renal transplant, and in fact, most of the time, these conjunctival SCC is a presentation usually found in older individual and unilateral. But rarely it can be bilateral, and it's most commonly seen in such immunocompromised condition. Location, as you all know, it's perilimbal, interpalpebral or bulbar conjunctiva, and it can also involve the cornea. There are different morphological types, and they are classified as elevated nodular type and the placoid type. The placoid type, as you can see, it can be gelatinous or it can be papilliform. There is yet another entity which I've not put the picture. It's the diffuse infiltrating squamous cell carcinoma. When you see this case, you would suddenly think it's kind of a pigmented conjunctival lesion. But if you see here, there is a lot of keratin over the surface, and in fact, pigmented races like Indians and Asians, you can also have the pigmented variant of conjunctival SCC, and this is exactly how it would look like. The clinical diagnosis and the pearls that you have to keep in mind is presence of keratin, rose Bengal staining, done clinical, feeder vessels, intrinsic vessels, the corneal encroachment, and scleral fixity. Scleral fixity is very important, and it can be easily done in the clinic. Take a cotton tip and try to move the lesion. If there is scleral fixity, that alarms you. That means there is more of invasion of the tumor. Always and always look for the presence of a regional lymph node, whether there is any regional metastasis present. Now, we have studied 127 cases, and it's a series of Dr. Hunavar, and we evaluated what are the clinical factors that would give us a clue whether it is a conjunctival invasive squamous cell carcinoma or whether it's any other benign lesion. In fact, we found that the presence of keratin, the vascular pattern that I mentioned, more so the feeder vessels and rose Bengal staining, has 97% sensitivity and 98% specificity in differentiating it from a benign lesion like actinic keratosis. Now, this is another case where it has extended the entire corneal surface. Yet another case. Now, you don't find much of a keratin on surface of this lesion, but it has got this nodular appearance. Any diagnosis? Clinically, can you actually say, oh well, this can be this type of conjunctival SCC? So we have these aggressive variant like spindle cell, we have adenocarcinoma, and the mucoepidermoid carcinoma. Usually the mucoepidermoid carcinoma, more than having keratin, they will be having mucus accumulated in that, mucoid accumulation. So usually they appear as an elevated nodular lesion over the surface. And more so, since being invasive, there are high chances that it can have an intraocular extension. So, as I told you, now, how do you know? There are certain situations where, you take the patient for a surgery, you don't want much of investigations to be done, but then there are certain situations where you really want to investigate. These are the situations, especially in the case of mucoepidermoid carcinoma, if you're suspecting clinically, you want to know the depth of the lesion. If at all there is an intraocular extent, the surgery would be enucleation. But then if you want to salvage the eye, you want to make sure that it is surface. In fact, even if it is involving the sclera, the eye can be salvaged. You can go for a lamellar sclerectomy. The patient can undergo plaque brachytherapy later, which will be dealt by Dr. Hunavar later. So OCT and UBM, yes, in fact, it helps. But there are certain situations where the presence of keratin will cause a lot of backscattering, and you may not be be able to actually know the depth of the lesion in certain situation in the presence of keratin. Now, in these situations where the patient is presented with advanced lesion, you definitely want to do a CT scan and know how the extent is. In fact, this patient underwent an exenteration. So these gelatinous or placoid lesions, it's easier to diagnose with OCT or UBM. You can clearly define the margin, you know how much is the extent, even the thickness, and it really correlates well with pathology. As I told you, but in lesions where there is keratin, there will be a lot of backscattering. This is exactly how it looks like. This is definitely an SCC, but then you have a lot of backscattering, you really don't know the depth of the lesion. AJCC classification is the clinical classification which is followed. It's not difficult because you can see the slide very crowded. It is classified generally into T1, T2, T3, and T4. T1 are those which are classified depending upon the size, which is less than 5 millimeter. And T2 are those with more than 5 millimeter. T3 are those which involves the adjacent structures, excluding the orbit. That means the cornea, the fornix, the caruncle. T4 are those which invades the orbit with or without further extension. So it's not that difficult as you see because, it's like T1, T4, so you can always do it clinically. Now, surgery is definitely the mainstay of treatment, which I'm not going to go into. One thing that I want to stress at this point of time is the surgical documentation. Now, when we talk about surgery, we always say that we want a margin of 4 millimeters. How do you assess that? You actually do it clinically under microscope. So when you talk about this lesion, exactly this lesion, you clearly assess the lesion, you clearly assess the size of the lesion, you assess how much it is extending into the cornea because you want to add corneal epitheliectomy into that. Now, the extent of the lesion really doesn't mean that it's only this nodular component. You have to look for the adjacent conjunctival thickening. That means the adjacent conjunctiva is also involved, and you in fact want to take out that. So your margins won't be 4 millimeters from the margin of the nodular lesion. Your margin will be 4 millimeters away from the conjunctival thickening. Going on to the next amelanotic lesion, conjunctival lymphoma, it is basically a lymphoproliferative tumor. In fact, it also has a spectrum of reactive lymphoid hyperplasia, benign lymphoproliferative tumors, and conjunctival lymphoma. As you all know, it's from our PG days, we have been taught that it has got a smoked salmon appearance. And this is classically how it looked like. Another clinical diagnostic pearl in diagnosing conjunctival lymphoma is that it would be having these corkscrew vessels in the lesion. It appears from somewhere and it disappears nowhere. This is how we have been taught by Dr. Hunavar. In fact, always look for its extension into the fornix. If there is a fornicial extension, that tells you that you have to image the patient to look for orbital extension also. Now, the most important thing that I want to stress here is the association with systemic lymphoma. There is a 17% association if it is unilateral and 47% if it's bilateral. That is huge. Now, the prognostic factors that tells you whether the patient would develop a systemic lymphoma anytime would be whether it's multifocal, whether it's bilateral, whether there is fornicial involvement or palpebral involvement. Now, association with systemic lymphoma, any patient of yours, they can have developed systemic lymphoma, 15% of them in 5 years and 28% in 10 years. What does this mean? That you have to have a long-term follow-up of these patients. After excision, don't let your patient go. At least do a 1-year follow-up for them. And the most common lymphoma that we find is the mucosa-associated lymphoid tissue, the MALT lymphoma, which is a non-Hodgkin's B-cell lymphoma type. In fact, there is a lot of histopathological overlap, and I'm sure Kaustubh is gonna cover on that. Another association after you get a diagnosis of MALT lymphoma is you want to suspect whether the patient has got a systemic infection of Helicobacter pylori infection. In fact, in the presence of Helicobacter pylori infection, if it is already diagnosed, there is a 5% chance of having MALT lymphoma anywhere in the body. Now, MALT lymphoma, if you diagnose, if it is unilateral, there is a 20% chance that the patient can develop systemic lymphoma later. If it is bilateral, there is in fact 50% chance that the patient can develop systemic lymphoma later. So, I want to stress at this point, a systemic workup is very, very important if you come across a lymphoma in your clinic. Now, going on to melanocytic conjunctival melanoma, basically it's more common in Caucasian, usually unilateral, elevated. Now, conjunctival nevus is already covered. It is a precursor lesion, and you can always diagnose with the presence of microcyst or macrocyst from conjunctival melanoma, already beautifully covered by Dr. Menon. And primary acquired melanosis is yet another malignant precursor. Now, what I want to stress here is, how do you actually know that your patient walking into your clinic, diagnosed with PAM, whether he would develop conjunctival melanoma, and how often you would like to follow him up? Now, this is a very beautiful paper put across by Dr. Shields et al., where they actually evaluated the clock hours and the probability of developing into conjunctival melanoma. So the relative risk is 1.7 times compared to 1 clock hour. It is, if it's 1, it's into 1, and if it is 10, it is like 17 times higher. Now, other features which can of PAM is involvement, the site of involvement, the location, involvement of tarsus, caruncle, upper fornix and lower fornix. There is a high chance of this being converting into malignant melanoma. Pathology will be covered by Kaustubh. I'm going to skip this slide. Now, yet systemic associations are also involved with melanoma. They are dysplastic nevus syndrome, neurofibromatosis, and xeroderma pigmentosum. Now, this is a patient, like you can see, a person with bilateral conjunctival lesions, and you can see this pigmented lesion over the forehead, whether it is like a systemic melanoma affecting the eye, or any diagnosis? A short quiz. Well, this is not systemic association. These are certain things which is very prevalent in certain countries where they go for tattooing and various other procedures. So it's nothing to do with this course, though. So this is how conjunctival melanoma would definitely look like. It will be fleshy, it will be elevated, there will be prominent tortuous feeder vessels and intrinsic vascularity. In fact, it can also be amelanotic. Now, but it has got these trace pigments over it. So 75% of melanoma develops from primary acquired melanosis, 20% arises from de novo, and this is 5% arises from conjunctival nevus. So this is the case that I showed you before. It is, you can classically see the demarcation between the nodular component and the cystic component. So this is the nevus developing into melanoma over there. All right, there are immunohistochemical studies that will help you to differentiate between the benign and malignant variety. I'm still not going into it. Now, the most important thing about conjunctival melanoma that I want to stress here than squamous cell carcinoma is the regional metastasis and systemic metastasis, which is very, very high. Now, this depends upon certain clinical features which you have to diagnose in your clinic: thickness of more than 2 meters, large basal diameter, nodularity, non-limbal location, positivity of the margin after excision, orbital extension, and de novo origin. Can you guess the mortality in conjunctival melanoma? Very, very high. It's 32% at 15 years. So you have to be very careful in assessing and even surgically treating these patients. It is also classified into AJCC classification. Now, this basically depends upon where the tumor is located. Bulbar, T1. If it is located in the palpebral, conjunctival, fornicel, and caruncle, T2, and if it is with local invasion, T3. And depending upon that, you actually classify into 1A, B, C, depending upon the quadrants. I'm not going into detail. So depending upon the AJCC classification, it has been seen that T2 and T3 has got higher rates of local recurrence, lymph node metastasis, distant metastasis, and death. Now, in these cases where the patient presents with you with a nodular lesion where you can really not make out the posterior extent of the lesion, you want to do a CT scan or MRI and image and see what is the extent of the lesion, which is very, very important. Regional lymph node examination is very important. If you does not get it clinically, there are situations where you want to go ahead and do a sentinel lymph node biopsy. Now, when do you decide a sentinel lymph node biopsy? When the tumor is more than 2 millimeter thick. That's what internationally everyone follows. Because if it's more than 2 millimeter thick, it's found that systemic metastasis is as high as 30 and regional lymph node metastasis is 18%. There are various studies which has come out recently telling that indication has to be more than 2 millimeters. In this paper, they had 11% patients developing regional metastasis, which was not diagnosed clinically, and in the other paper, it was 16. There are certain other malignant lesions where you can have metastasis of the conjunctiva. This is a case of skin melanoma metastasizing into the conjunctiva. Even leukemic infiltrates can be present and other malignancy can be present. Now, this is a case of nevus of aorta where the patient had these pigmentation that you can see. It is actually an intraocular melanoma extending extraocular. So this patient never had a follow-up. It was just like a nevus of aorta, a benign lesion. The patient was happily moving around until she found sudden reduction of vision. So she developed a nuveal melanoma, and it has been advanced to a stage where it has got an extraocular extension. Still thought that it's a part of nevus of aorta. Now, any diagnosis? Very vascular lesion, malignant. Kaposi sarcoma. So it's usually seen in immunocompromised patients. Sometimes, very rarely, this can be the first manifestation in an immunocompromised patient. Presents as a subconjunctival hemorrhage or a hemorrhagic conjunctivitis. Rhabdomyosarcoma very rarely can present in the conjunctiva, most commonly with the embryonal type. The botryoid usually can present as a phoneal mass also. Now, this is something that I really, really want to stress here on conjunctival malignant lesion. Any diagnosis? And this is my last slide. I heard something from that corner. Sebaceous, yeah, exactly. So sebaceous gland carcinoma of the eyelid. It is an eyelid tumor. But there are situations where you can have an intraepithelial invasion of SGC. So here you can see the diagnostic pearl over here is the affection of the meibomian gland architecture. It's totally altered. There is complete loss of eyelashes over here in this portion. You can see thickened tarsus, which is yellowish in color, and still you have this diffuse conjunctival congestion, thickening of the posterior border of the lid margin. So if a patient walks in like this, please don't diagnose it as a chronic blepharitis, but in fact it is a conjunctival invasion of a sebaceous gland carcinoma of the eyelid. So to conclude, wide clinical spectrum of conjunctival malignant tumor and benign is there. We should be able to differentiate at the right time early diagnosis from a benign tumor and a malignant tumor. Accurate clinical diagnosis is essential, and a meticulous clinical examination and documentation is also warranted. Always looks for signs of regional as well as systemic spread, and if needed, please go ahead doing imaging like MRI and CT scan. And it has got excellent tumor control if you diagnose it early without missing it, and protocol-based management has got excellent outcome, which Dr. Hunavar is going to discuss with you. Thank you.